Good evening, everyone. I am Adafshin on behalf of IGCP. I warmly welcome to all our respected doctors and participants for today's digital live session. We are meeting today on the occasion of Maternal Health Awareness Day for a very important and thought-provoking topic: red flags in maternal health. What every clinician must not miss. Maternal health remains the backbone of a healthy society, and timely recognition of warning signs can be truly the difference between life and loss. This session aims to highlight those critical red flags that every clinician must be alert to across antenatal, in-partrum, and postpartum care. Introducing our moderator, it is my privilege to introduce Ma'am Dr. Bharti Kalra Ma'am. She is the consultant obstetrician and gynecologist in Bharti Hospital in Karnal. Dr. Bharti Ma'am is a highly respected clinician known for her commitment to women's health, safe motherhood practices, and clinician excellence. Her vast experience in compassionate approach make her the perfect moderator to guide today's discussion and bring together diverse clinical perspectives. With great pleasure, I now invite Dr. Bharti Kalra ma'am to take over the session and introduce our other panel of experts. Ma'am, this is over to you. You can proceed with the next. Thank you.
Thank you, Ada. This is a great opportunity for me to conduct a session on red flags in maternal health. We know women hold up half the sky. That is the saying. But is it true for our problems too? Because we take care of a additional responsibility of giving birth to a child, to bringing a new generation into this world. So with this comes the share of problems with us. So what are the red flags which warn us, which warn our society, clinicians, which should never be missed in taking care of our dear women and the future generation? So today I have expert panelists with me. Those who will, with them, I will be discussing about the problems and how that can be tackled. Slides, please. So in the topic of red flags in maternal health, I have three esteemed panelists, Dr. Meenu Thakur. Dr. Meenu Thakur, ma'am, she is women health specialist at Thakur Eye and Maternity Hospital, Karnal. She is in private practice for more than 35 years and past president of Karnal Obs and Gynae Society. And she has special interest in preventive health care for women. Welcome, ma'am, to this esteemed panel.
Thank you.
And next is Dr. Manisha Singhal. She is working at Mahabir Dal Hospital in Karnal as OBG consultant for more than 13 years. And she is presently Secretary of Karnal OBG Society with special interest in high risk obstetrics. Welcome, Dr. Manisha.
Thank you, ma'am. Namaskar.
And to add to this panel, we have Dr. Shubhangi Katyal. She is working at Haryana Nursing Home, Karnal. Has more than 10 years of experience in private practice, and she is trained in obstetric ultrasonography and certificate course in GDM. And she also has a special interest in high-risk obstetrics. So with the team of these expert esteemed panels, we will see what are their views and how they do in their practice and how do they suggest to their patients as well as their family members and their staff as well as the other clinicians, other doctors whom we need help at any times. So welcome you all. So as we know, maternal health is very, very important, as already said. And Global Maternal Health Awareness Day is celebrated on 23rd of January. So on eve of that, 23rd of January, means today on 22nd of January, we are conducting this session. And although in India, 11th April is celebrated as National Safe Motherhood Day, and for the global, because global community is celebrating on 23rd of January, and this year they have taken the theme as holding grounds on maternal health. In India, we know we have come a long way. We have reduced our maternal mortality to 88 per lakhs live births, and we aim to reduce it to less than 70 by 2030. So how can we achieve it? Our government has tried very heavily with the starting of PMSMA, that is Pradhan Mantri Surakshit Matritva Yojana, and increased institutional birth with their policies, which has helped us reduce the maternal mortality. But Dr. Meenu ma'am, why the maternal health matters? What are your views about it?
Women play a very important role in society. They are mothers, they are sisters, they are working people, they are professionals. They are so much in one. Without them, the like world cannot exist. Of course, you mean all know world doesn't exist without women. They are the center point. और धुरी बोलते हैं ना पूरी पूरे घर की भी धुरी है. अब तो बाहर भी धुरी है हर चीज की. तो their life is very very important. And when we talk of maternal health, we're talking of two lives. It's not one life. We're talking of two lives. कहते हैं ना ईश्वर ने जो औरत को बनाया ना अपने जैसा बनाया है, सृजन की शक्ति दी है ना. तो जैसे ईश्वर सृजन करता है, तो ये तो बहुत ही इंपॉर्टेंट है उनकी हेल्थ. तो ये ठीक रहेंगी तो पूरा समाज ठीक रहेगा, पूरा घर ठीक रहेगा, पूरा समाज ठीक रहेगा, पूरा विश्व ठीक रहेगा. जी.
दूसरा एक इकोनॉमिक रोल, दे प्ले इकोनॉमिक रोल. अगर because they hold up half the sky, that means they contribute to more than earning to their family as well as in the society. हम अपने यहाँ ही देख लें, हम खुद भी women हैं, हमारा staff भी maximum women होता है. तो everyone has given birth and they are taking care of their kids as well as they are earning member of their family also. So that is why their health is very very important to us. और जिस माँ ने बच्चे को पैदा किया है उसको पालने की एंजॉयमेंट तो मिलनी चाहिए ना. उसकी तो हेल्थ हमेशा अच्छी रहनी चाहिए. जब माँ स्वस्थ होगी तो बच्चा भी जिंदगी भर स्वस्थ रहेगा और वो अच्छा आचरण करेगा, अच्छे समाज में रहेगा. पर वी हैव मेनी कंडीशंस व्हिच आर लेबल्ड एज रेड फ्लैग. डॉक्टर मनीषा, व्हाट आर द रेड फ्लैग्स? प्रेगनेंसी तो सदियों से होती आ रही हैं. Why we talk about these? What are these, please?
So red flags are some danger signs which which are the indicators of some potential danger, and we should be need immediate attention. So we should inform about these red flags to the attendant and the relatives and even in the partner of the patient. And red flags in pregnancy are like vaginal bleeding or discharge and excess high grade fever with chills, sometimes bleeding and syncope, even breathlessness, and sudden weight gain or swelling all over the body. So the patient and the relative should be informed about such red flags so that they can take the immediate help in case of any red flags if they see.
In our OPD, we see patients come prior to conception. Is that important? Means there is another condition called zero trimester. That is the new term coming.
Yes, the concept of zero trimester is there. It's a new concept, but it's very important regarding the patients and the partner's health. Their immunization can be done, about their any genetic counseling can be done in this case, and we can advise them healthy diet and even exercise for the better outcome if they are planning for the conception. And even folic acid should be started before the pregnancy in this zero trimester.
Yeah. So, Dr. Shubhangi, is there any role of partner also? Means the husband?
Yes, definitely, ma'am, because the partner also contributes the sperm, and his well-being is also very important. Especially, we need to see the thyroid function, BMI of the husband, VDRL status of the husband, and how much he is also into starting a family. After talking to both of them, we can come to know about all these things.
Dr. Meenu ma'am, are the only physical parameters important or emotional health is also important before planning pregnancy?
Definitely. I think pregnancy should come when it is planned. When the mental preparation is there with the would-be father and the mother, that they want the pregnancy. Because what vibes you are going to give to your baby is going to matter a lot in the emotional health of the baby in the long term. Sometimes the pregnancy just happens. Newly married couple आता, they say we don't want the baby. They'll go from one doctor to another. एक समझाएंगे, मैं समझाऊंगी, okay. First pregnancy है, ऐसे नहीं करो, continue करो, whatever it is. Then they'll go to Dr. Bharti or say go to third person कि मुझे तो नहीं चाहिए ये, मुझे बिल्कुल नहीं चाहिए, मुझे मना कर दिया गया है. मतलब मेंटल प्रिपरेशन होगी तो बहुत इंपॉर्टेंट है. इमोशनल हेल्थ बच्चे की वाइब, सिर्फ बच्चे को आप खुराक नहीं दे रहे, आप वाइब्स दे रहे हो, आप अपने थॉट्स दे रहे हो, सब कुछ दे रहे हो.
Garb
preparation,
sanskar.
definitely. हाँ, गर्भ संस्कार, yes, that's the right word.
Definitely.
बाकी फोलिक एसिड और ये सब इन्वेस्टिगेशन तो इम्पोर्टेंट है ही है कि कोई मेडिकल प्रॉब्लम ना आए. कहते हैं ना, जन्म पत्री मिलाने से पहले कहते हैं वो प्री कंसेप्शनल और प्री मैरिटल की बात अगर करें तो कहते हैं थैलेसीमिया का टेस्ट करा लो जी पहले ही, है ना. और ऐसा कुछ प्रॉब्लम आए कुछ बाद में HB इलेक्ट्रोफोरेसिस करा लो पहले से, ताकि वो जरूर मिला लो कि दोनों तो नहीं है कहीं मेजर, आगे प्रोजेनी के मुश्किल आएगी. तो पत्री ना मिलाओ पर एटलीस्ट मेडिकल तो देख लो. और फिर ऑफ कोर्स इमोशनल, जैसे आपने बताया, mental preparation is very important besides the vaccination, rubella, varicella, and the weight, the control of weight and everything.
Dr. Manisha, because obesity is on increasing trend, so do you recommend weight loss prior to conception? So how do you counsel?
Yeah, definitely weight loss of both the partners is important for conception. So we'll advise them healthy diet, some yoga and meditation, will that so that they have a healthy lifestyle and healthy bodies.
And Dr. Shubhangi, the girls coming with the irregular menstruation, PCOS, so what do you suggest them? Are these also red flags before
Yeah,
planning pregnancy?
definitely, because
Yes.
in cases of PCOS cases, the women may have GDM, gestational diabetes also, and they have early miscarriages also. These cases, because they have low progesterone support, and plus their children, their babies may also lead to get diabetes or obesity in later life. So, in case of PCOD patients, we always advise lifestyle modification, especially by diet and exercise. Sugar, ghee, and maida should be totally avoided. Junk food should be totally avoided, and they should at least exercise 40 to 50 minutes, at least 5 days a week, and lose at least 10% of their body weight before conception. If they are
Any
obese,
Any basic investigations which lead to healthy motherhood, which we get in routine hour? What we want to optimize prior to conception, the 4 parameters for optimization, 4 or 5 parameters before planning pregnancy.
yes, ma'am. Actually, overall, the health, entire health checkup, even the vitamins, vitamin D, vitamin B12, we need to check. We should start folic acid before conception, and then the thyroid status, HbA1c status. If there is history of diabetes in family, we should do that, and we should ask about the vaccination also. So if she is not immune to rubella, so we can tell her to get the vaccination done, and wait for at least 3 months to start her family life. And if she is mentally or physically not ready, so she should read more about everything, the preconceptional things. And if she's doing smoking, she's taking alcohol, we should tell her all these things need to be completely set apart. Then if she is taking more of caffeine, like आजकल के बच्चे black coffee बहुत ज़्यादा consume करते हैं, तो वो उसके लिए भी टी एंड कैफीन इंटेक शुड बी अवॉइडेड. ऑल दीज थिंग्स. और कोई भी मेडिकेशन अगर वो है, कोई any medications which are not, she should stop before conception. So we should ask about that history also, and get all the investigations done which are in normal routine health package. And if there is any deficiencies, we must complete that before she gets pregnant.
That's very good. That prior to conception, we should optimize with folic acid and vitamin D, that this supplementation should be continued, and we should optimize hemoglobin, blood glucose, thyroid status, BMI, as well as blood pressure with the safe medications if needed. So if the pregnancy enters into in the healthy conditions, the outcome will be good. So there will be less red flags in coming time. So, Dr. Meenu ma'am, what are the red flags in first trimester of pregnancy? A patient has conceived, she is very happy with pregnancy test positive, and something wrong happens. So, what are the things which make us very watchful, and we should consider them while treating the patient?
Any pain abdomen with or without bleeding, that is the first thing. That is one of the red flags. Then, of course, her tests have to be done. No, the thyroid, the blood sugar. If anything comes out to be abnormal, we have to correct it. Basically, thyroid should be corrected before conception, because by the time we detect pregnancy, it's already patient is already 15 days already passed. So this has to be done pre-conception. Basically, the ho jaye to at least patient will come after pregnancy, after she conceives only. So thyroid karana hai. And then any headache, fever, any infection anywhere in the body, we have to look for that. We can get a CBC done. Any infection anywhere. Blood pressure, if it's high. Sometimes patients have hypertension before pregnancy also. They'll come to you first time in pregnancy only. So we have to look after that as well. Blood sugar.
These are the routine tests.
Pardon me?
Routine tests we have to do.
Routine tests, all the
Ultrasound.
viral markers, thyroid viral markers, blood sugar, hemoglobin. These tests all should be done because we have to look at the basic tests first, no? Haji.
So it's said that pain abdomen and bleeding PV, if they occur together, that is a hazardous combination for continuation of pregnancy. Alone pain can be managed. Alone bleeding might or might not be 50-50 chances. But if both are occurring, so there is risk of ectopic pregnancy or abnormal pregnancy that may not.
We have to think of ectopic. We have to think of
Yes.
ectopic. If we don't think about it, we might miss it. We have to. The eyes don't see what the mind doesn't know. So we have to always think of ectopic. Any pain. Sometimes patients says thodi pain ho rahi hai, and I've seen them landing up with a full blown ectopic rupture or something like that. So ध्यान नहीं रखेंगे तो this can also happen.
Another thing, fever with rash. In first trimester, patients usually miss. थोड़ा सा तो बुखार हुआ था, उसमें थोड़ा सा फेस पे रेडनेस हुई थी, and they come with the rubella positive later on in pregnancy. So we have to ask proactively if they have any fever. So we have to be very diligent in examination and investigations for them. So then in those cases, we have to rule out rubella infection. So that's very nice. And if pregnancy is abnormal, then we have to counsel them because that may affect their future pregnancies also. Luckily, pregnancy has crossed the first trimester. Patient has overcome the hyperemesis because these are the very common symptoms. कि वो तो कुछ खाती नहीं और सबको प्रेगनेंसी में होता है, कोई बात नहीं, चलता है. ऐसे पेरेंट्स कहते हैं she is just in shock or maybe she is just unconscious and dehydrated. She has lost weight. Might be I have seen patient losing up to 5 kg in 1 month of conception. So in those cases, we have to be very vigilant for that. Proactively ask the history, as well as the attendant should be informed. It's not everyone gets severe vomiting in first trimester, so they should be willing to take action and get her admitted and get treated properly. So
in case of severe vomiting, I want to add two things. two different scenarios which I came across during my practice. एक गॉल ब्लैडर और लिवर को रूल आउट करो जब भी यू गेट अ एक्सेसिव वॉमिटिंग केसेस. एंड वन केस आई गॉट द पेशेंट इन डायबिटीज कीटोएसिडोसिस. हाँ, उसकी जो कीटोटिक स्मेल थी दैट गेव मी द सेंस कि आई शुड डू अ रैंडम ब्लड शुगर ऑफ द पेशेंट एंड उसकी शुगर 500 से ऊपर थी मैम. सो दीज आर सर्टेन कंडीशन जहाँ पे हमें कभी कभी हट के सोचना पड़ता है कि ये प्रेगनेंसी की वजह से नहीं, कोई और कारण भी है, हो सकता है, कुछ और भी हो सकता है.
So hyperemesis may lead to dehydration, ketosis. Yes, and another important, if we get patient is having excessive vomiting and we get her thyroid test done, she may report may come out to be of thyrotoxic. Yes. So we have to be very vigilant before starting medication. We have seen doctors starting anti-thyroid medicines, and that is just because of hyperemesis and they continue. That is very important warning symptom. So in first trimester, we may encounter pain, bleeding, as well as the vomiting. These are the common scenes. And if she has unusual features of fever or fever with rash, or at times the unusual vaginal discharge. So repeated UTIs can be common, and that may lead to pain abdomen. So we have to investigate on that line also. So first trimester is over, and now she enters the second trimester and third trimester. So these usually run smoothly. We say it's second trimester is the honeymoon phase of your pregnancy, but sometimes things go wrong also at that time. So Dr. Manisha, what is your opinion in second and third trimester about the warning symptoms?
In second trimester also same मैम, अगर bleeding हो रही है या severe pain है Yeah, she's complaining of decreased of loss of fetal movements or sudden weight gain or excessive swelling all over the body. If she is having some severe headache with blurring of vision, we should look for PIH. These are the warning signs.
So, any role of weight gain, rapid weight gain? What could be the cause of rapid weight gain?
So it could be in PIH also because of the edema, or it could be in diabetes. She may have excessive weight gain
Otherwise, the
or
increased diet,
polyhydramnios,
excessive calories, and decreased movement.
decreased
Patient
movements.
And
having
Yeah,
that.
decreased serum albumin also, ma'am.
Yes.
yeah,
Hypoalbuminemia.
hypoalbuminemia. Yes,
Ma'am, do you
or
encourage
anemia,
Hypophosphatemia.
exercise
even anemia.
in pregnancy, Dr. Meenu, ma'am?
Do you encourage
Exercise.
what?
Exercise. Which
Yes,
Very
type of exercise?
moderate,
yeah, moderate
uh,
exercise,
very
especially.
moderate. I mean, not strenuous exercise, moderate walking. She should be active. Patient should be active during pregnancy. And even pranayams, except for Kapalbhati, we says थोड़ा प्राणायाम भी करो, mild सी सूक्ष्म व्यायाम जैसे बोलते हैं, थोड़ा थोड़ा जरूर करो, because otherwise they'll go on eating and they'll gain weight.
So, what are the harms if patient goes for bed rest in pregnancy? कि डॉक्टर ने मुझे बेड रेस्ट कहा है या मुझे तो प्रेगनेंसी है, I should enjoy my life with all the help around. Should we encourage activity
No,
and
we
give?
should encourage activity if
Yes,
all is
yes,
good. If
definitely.
bed rest, so in special cases like a low-lying placenta or threatened abortion, or that's a separate thing. Otherwise, the one should be active. Patient should be active throughout. We should encourage activity, moderate activity, and otherwise he'll put on so much of weight, obesity हो जाएगा, BMI बहुत चले जाएगा high. That would.
Dr. Shubhangi, what about the headache and blurring of vision? So, how will we say that your headache is normal or abnormal? It's common.
Ma'am,
It's a sign of sign and symptom of something untoward.
yes. If the patient is having severe headache along with blurring of vision and upper abdominal discomfort or pain because of capsule stretching of the liver, or she may experience decreased urine output or sudden swelling in the body, these are all the signs of preeclampsia. So we must look into and do specific tests like CBC, liver function test, serum uric acid, urine for albumin, and we should see if the urine albumin is positive. We must take steps to control the hypertension, and if the patient may require magnesium sulfate also. So we should be very, very, very careful, because otherwise the patient may land up into eclampsia also.
Uh, Dr. Manisha, if patient complains of excessive vaginal discharge, so is that a warning in second trimester?
Yes, ma'am, it definitely, because it can be a leaking or some vaginal infection. So we should look for the an ultrasound should be done to rule out any leaking, and vaginal examination should be done for the ruling out the infections like candidiasis or bacterial vaginosis and type, and it should be treated because it may lead to PROM, pro
So,
Preterm labor.
preterm
how
labor
frequently
and PROM.
consult a gynecologist or any health
In sec-
care specialist in during pregnancy? How frequent? Because if patient is at home and we don't tell her that you can, if you have any of these problems you should visit hospital, but otherwise how frequently do you recommend?
Ma'am, in first trimester we recommend four weekly, but in second trimester then we advise them to visit at least three weekly, twice weekly or after 2 weeks or 3 weeks. But in third trimester, every 2 weeks they should visit the doctors.
So
For
if we find any of
checkups.
these abnormal symptoms and signs, the patient should visit immediately, and that we
Yes,
should
yes.
convey to them as well as their family members too.
Family members. Yes.
So these are the basic investigations we will like to do. Dr. Shubhangi rightly said we should go for the LFT and KFT initially. And nowadays the very important investigation is with the ultrasound. So at times we tell them do this, do that. You need ultrasounds for all these things. So Dr. Shubhangi, can you enlighten us of the role of ultrasound and what we come to know? And if we need to go for single ultrasound, what is the best time for that?
After pregnancy, ma'am?
Yes, yes.
Postnate. Okay. First ultrasound should be done as early as 5 to 6 weeks, and it should be mostly transvaginal sonography. And it mostly dating and viability scan can be combined. But if a patient is complaining of some discomfort or pelvic pain, especially one-sided pelvic pain, then we may have to do ultrasound as early as 5 weeks. Then viability scan around 6 to 7 weeks, where we can rule out ectopic pregnancy, do the dating and see the cardiac activity. And if there is any ovarian cyst or fibroid, if it is present, so likely precautions which the patient has to take, we can tell them, and the risk involved with those things, the size of the fibroids, the position of the fibroids or ovarian cyst, the torsion may occur during pregnancy. We can counsel all that beforehand and tell them the warning signs and symptoms for for torsion of pregnancy, or in case of fibroid, there may be preterm labor, there may be leaking PPROM, and she may land up into early delivery, and newborn complications may be there because of extreme preterm nature. So we can counsel everything during that after the first scan. And if that scan is totally normal, then we can go for NT scan, which is done between 11 weeks 3 days to 13 weeks 6 days mostly. The NT should be normal, the nasal bone should be seen, and there are many other parameters which we see in this NT scan rather than just the viability of that. The one of the main things is uterine artery Doppler flow. If the uterine artery Doppler indices are raised, there is raised PI or there is more resistance, we should definitely add ecosprin to the mother. If she is around 40 kg or 50 kg, we should give her 75 milligram of ecosprin. Otherwise, if the patient is a little on a heavier side, obese, and there is very high resistance in uterine arteries, especially both uterine arteries, then we should supplement her with 150 milligram of ecosprin. And if there is only unilateral increase in uterine artery blood flow, so the side which has placenta implantation, that side uterine artery PI is always more important. For example, if the placenta is on the right lateral side, and the right side uterine artery PI is showing more resistance, then it is very, very important to add ecosprin, and tell the patient also that you have to take this ecosprin, because most of the time they do is they don't take medicines. तो हमें उनको समझाना पड़ेगा कि ये दवाई खाने से ये होगा, ये आपका प्रीटर्म बर्थ प्री क्लैम्पिया में नहीं जाओगे, आपके बच्चे की ग्रोथ अच्छी होगी, नहीं तो बच्चे को जो खाना पीना मिलना है ब्लड फ्लो के थ्रू वो कुछ भी नहीं मिलेगा. सो एंटी स्कैन, and if the NT scan is totally normal, then we go for anomaly scan between 18 to 20 weeks. And if NT scan is showing some abnormalities like absent nasal bone or unossified nasal bone, we go for early anomaly scan at around 16 weeks, and preferably by a fetal medicine specialist. Otherwise, if it is everything is normal, anomaly scan is done between 18 to 20 weeks. After that, we can advise fetal echocardiography around 20 to 22 weeks. And fetal echocardiography, I must say, if you're not doing in each and every patient, we must do echocardiography in cases of GDM, gestational diabetes, already overt diabetes mellitus patient, SLE or other systemic connective tissue disorders, twins pregnancy, we should definitely do fetal echo, single umbilical artery, where that can be associated with other cardiac malformations, and fetal arrhythmias for sometimes. Actually, the time is 20 to 24 weeks for doing fetal echo, but अगर कभी-कभी CTG पे 26 weeks के बाद भी आपको fetal arrhythmias मिलते हैं, so we should definitely go for fetal echocardiography. And if the patient's BMI is more than equal to 30, that is also one of the indication of doing fetal echocardiography. Plus, when there is a history of congenital heart disease in the previous newborn of the same couple, or their first degree relative of both maternal or paternal family, then also we should advise fetal echocardiography. And when the patient is on certain medications, for example, किसी patient ने कभी किसी chemist से दर्द की दवाई लेके खा ली है, वो NSAID थी, then we must tell them to go for fetal echocardiography, because it may lead to premature closure of the ductus arteriosus and साइनोटिक हार्ट डिजीज. सो ऐसे ही अगर हम जैसे इंडोमिथासिन यूज करते हैं कभी कभी इन पॉलीहाइड्रोमनियोस केसेस और इन केसेस में, तो उसमें भी फीटल इको हमेशा एडवाइस करनी चाहिए patient को. After that, we go for a growth scan around 28 to 30 weeks of gestation. And if the growth scan is completely normal and the patient is having normal fetal movements, everything is normal, the abdominal girth is normal, everything, fundal height is fine, then we may not require color Doppler scan in the later period. But if there is any hypertension and we are expecting less fundal height, or in growth scan there was IUGR or macroscomia, so we may have to go for other color Doppler scans. And if the patient sometimes tells decreased fetal movements or loss of fetal movements, we may have to go for USG for biophysical profile, in which the ultrasoundologist gives around 8 to 10 minutes in seeing the fetal tone, fetal breathing movements, and fetal movements, and give a clear picture of the fetal well-being. That's it. And in especially, I want to add, in twin pregnancy, if it is a monochorionic pregnancy, we may have to do ultrasound every 2 to 3 weeks in the later half of the pregnancy. And in cases of diamniotic dichorionic pregnancy, also we may need 3 to 4 weekly ultrasound scans, more ultrasound on. In dating and viability scan, the multiple pregnancy also has to be taken care of. If it is a multiple pregnancy, मोनोकोरियोनिक और डाइकोरियोनिक, वी हैव टू टेल देम कि आपके ज्यादा स्कैन्स होंगे, हमें मॉनिटरिंग, 2 बच्चे एक साथ बड़े हो रहे हैं या एक बच्चा एक कम बड़ा हो रहा है, हमें पेट से नहीं पता चलेगा. वी विल हैव टू डू अ रिपीटेड अल्ट्रासोनोग्राफी एग्जामिनेशंस टू नो कि कोई डिस्कॉर्डेंट ग्रोथ है कि नहीं 2 बच्चों की. तो ऑल दिस.
डॉक्टर मनीषा, अगर हमें प्रेगनेंसी में सिर्फ एक स्कैन करना हो, व्हाट इज द बेस्ट टाइम? इतने सारे अल्ट्रासाउंड तो हम सब पेशेंट्स के नहीं करा सकते. अगर किसी की बिल्कुल अनइवेंटफुल प्रेगनेंसी चल रही है, उसमें कुछ दिक्कत नहीं हुई, तो क्या तब भी हम अल्ट्रासाउंड बोलेंगे? अगर बोलेंगे तो कब? व्हाट इज द बेस्ट टाइम?
Ma'am, best time is for the anomaly scan, that is 18 to 22 weeks, so that we can rule out any anomalies.
Okay, that must be done for each and every
Even
pregnancy.
एक ही कराना है तो 5th month में मैम इम्पोर्टेंट है anomaly के लिए.
Because financial load भी काफी हो जाता है. और अगर हम
it can also rule out the placental implantation, any resistant flow, ये सारा कुछ भी पता चल जाएगा उसमें.
Thank you. So patient has crossed her 9th month and she has come in labor. So what are the warnings for us or anyone at home? Because कई बार हमने देखा है कि आधी रात को पेशेंट रात के 2 बजे आ रही है और उसको सुबह से पेन थी और वो बिल्कुल बेहोश जैसी हो रही थी, और करके कह रहे हैं कि नहीं जी पेन ले रही है, कोई दिक्कत नहीं, इसको तो 2 दिन से पानी भी पड़ रहा है, लीकिंग की हिस्ट्री भी है. तो what are the red flags during that time which warn us that we should be very careful for that patient? Ma'am, Dr. Meenu ma'am.
See, this is very tricky, because if patient is having leaking, she's going to get infected. So patients, we have to explain to the relatives and the patient that they have to come when they have little pain only. They may come before time, that's good. Because when they come in the daytime, all of us are ready for them also. Sometimes they'll keep waiting कि शाम होगी, रात होगी, तब जाके जाएंगे डॉक्टर के पास. सारा the whole paraphernalia, the whole system of the hospital is also and closing up at that time. Because दिन में आएंगे, they'll be attended better. We'll look after them better. So they should come as soon as they think anything is not normal. Any bleeding, any rupture memories, any discharge, excessive discharge, any fainting, any fever, any problem, they should not just sit at home. The relatives should be explained more than anything. Pain सिर्फ ले नहीं रही है, don't go on waiting. ये बहुत करते हैं, very commonly they have been doing this कि wait करेंगे घर में. लीकिंग के साथ तो बहुत, फिर infection हो जाएगी, then मुसीबत तो डॉक्टर का obstetrician की हो जाएगी. और हाँ जी.
Dr. Manisha, what are the 4 main components, means the 4 main complaints for which we warn our patients and which we want our ANMs or the junior staff should know, in which patient must come? What are the 4
alternative period or
yeah, during labor and delivery process?
Yeah,
हम जब पेशेंट बोलते हैं कि इनमें
Ma'am, any kind of antepartum hemorrhage, infection, severe high grade fever, even if she is having some convulsions or headache, severe headache with swelling, तो ये सारे points हैं. If she
Otherwise,
is having
routine
some
में
leaking,
if she is going in labor, if she is having bleeding PV, leaking
Decreased
PV,
fetal movement.
decreased fetal movement और labor pains, पेशेंट्स बोलते हैं कि हमें तो लेबर पेन्स का पता नहीं चलता है. बहुत बार ऐसा होता है कि they just deliver in bathroom. So which type, how will we convey this is a warning that you are going in labor?
ma'am, if she is feeling some tightness of abdomen with decreased fetal movement, with जो भी मतलब frequently she is having the tightness of abdomen, then we should advise कि ये इस तरह का labor pains होते हैं. जो आपका अगर
If she
बच्चा
is having,
इकट्ठा हो रहा है,
yeah, नहीं, continuous बैकएक may not be labor, पर अगर रुक रुक के
बैक
पेट में दर्द हो रहा है या
रुक
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 And
के
के
that
हो
कमर,
रहा है. हाँ जी, हाँ जी, contraction
दर्द पेट से कमर में जा रहा है या कमर से पेट में आ रहा है, if they
पेट में
are
आ रहा है
getting
बस.
tightness, even if they are not feeling tightness, अगर रुक रुक के उनको पेट में या कमर में दर्द हो रहा है, then they must come. So these are the warnings. पर at times वो आने से पहले बोलते हैं कि मदर इन लॉ ने घी पी ले, बच्चा फिसल के आ जाएगा, नॉर्मल डिलीवरी हो जाएगी, जल्दी अस्पताल जाओगे तो डॉक्टर ऑपरेशन कर देगी.
सीजरियन
What
हो
are your
जाएगा ये
views about it, डॉक्टर शुभांगी?
मैम आई टेल यू वन केस. एक बार ट्रांसवर्स लाई था, सो आई टोल्ड देम कि आपको घर में जैसे ही कुछ भी लीकिंग पीवी, पेन एब्डोमेन कुछ भी होता है, इमीडिएटली यू हैव टू रश टू द हॉस्पिटल. घर बैठ के पेन नहीं लेने हैं. एंड दे थॉट कि डॉक्टर ने जाते ही ऑपरेशन कर देना है, और वो घर बैठ के सच में पेन लेकर आई, पेन लेके, और उसको लीकिंग पीवी थी. थैंकफुली भगवान की दया से फिटल हार्ट भी थी, कॉर्ड प्रोलैप्स भी नहीं था, हैंड प्रोलैप्स भी नहीं था. एंड वो आई तो हमने उसका मतलब वही मैम की बात ना, ऑब्स्टेट्रिशियन की जान अटक जाती है, इनको पेशेंट्स को कुछ फरक नहीं पड़ता. Even after explaining the red flags, I already told that patient कि whenever you experience leaking PV or pain abdomen, immediate hospital, you have to rush to the hospital. Still she didn't come. So definitely. Yes ma'am.
Yes, sir.
नहीं नहीं, आप चलो, you finish your talk. Finish what you're saying. मुझे
वही है
कुछ
मैम.
ध्यान आ गया.
सो वही लीकिंग पीवी हो, persistent increase in intensity also, and regular pain intervals हो, शो अगर हो, ब्लड मिक्स्ड विद म्यूकस हो, थोड़ा वो भी लगे तो भी आपको हॉस्पिटल आना है, या डिक्रीज फिटल मूवमेंट या लॉस ऑफ फिटल मूवमेंट रहे तब भी आपको करना है. एंड डिक्रीज फिटल मूवमेंट मीन्स कि आपको एक घंटे में 2 से 3 से कम मूवमेंट हो रही है, या फिर आपको लॉस ऑफ फिटल मूवमेंट में है, मतलब आपको मोर देन 2 आवर्स हो गए, आपको कोई मूवमेंट नहीं महसूस हुई है, कुछ नहीं है, आओ डॉक्टर चेक करेंगे, एक एनएसटी करेंगे, अगर ठीक लगेगा तो भेज देंगे आपको, अगर ठीक नहीं लगेगा एक दिन रात के लिए रख लेंगे, मॉर्निंग में अल्ट्रासाउंड कराएंगे, अगर खुद के पास फैसिलिटी है तो वहीं पे अल्ट्रासाउंड करेंगे, सब कुछ एटलीस्ट कुछ होगा तो डिटेक्ट करके एटलीस्ट वी विल बी एबल टू ट्रीट यू. इफ यू डोंट कम, वी कांट ट्रीट यू.
इवन मैम पोस्ट डेटेड पेशेंट्स को भी एडवाइस करना चाहिए कि अपनी ईडीडी तक तो वो आ ही जाए. मतलब पेन्स नहीं आते ना तो वो विजिट ही नहीं करते डॉक्टर्स को, कि जब पेन्स आएंगे तभी जाएंगे. फिर कभी आईयूडी निकलता है, ओवरड्यू हो जाते हैं 10 डेज 15 डेज, फिर प्रॉब्लम आती है. तो वी शुड इन्फॉर्म देम कि जो ईडीडी है लास्ट आपकी एक्सपेक्टेड डेट है, उस दिन तक तो आपको विजिट करना ही है.
मुझे एक पेशेंट याद आ रहा है, मैं जस्ट इंटरप्ट कर रही थी कि उस पेशेंट शी वाज इन ट्रांसवर्स लाई, शी केम इन लेबर मिडल ऑफ द नाइट, जैसे ही पीवी किया तो कॉर्ड हाथ में थी. अभी तो बहुत दिन हो गए ऑब्स्टेटिक्स छोड़े हमें, लेकिन मुझे तब का वो भूलता नहीं है. उसको कॉर्ड प्रोलैप्स पुश किया, हाथ वहीं, और एनेस्थीसिया इमीडिएटली एनेस्थेसिस्ट को इन्फॉर्म करके, तब पुराना जमाना था तो कैसे शिफ्ट किया उसको थिएटर में, और बेबी वाज सेव्ड. बट इस तरह की हालत जब करके आते हैं तो लगता है कि हमने क्या पाप किया भाई, तुम्हें समझ क्यों नहीं आती बात की, क्या समझा के भेज रहे हैं तुम्हें, है ना. दैट वाज अ नाइटमेयर. तो दैट बेबी वाज सेव्ड ऑफ कोर्स, बट कैसे वो हाथ में जैसे एग्जामिन किया तो रप्चर मेम्ब्रेन्स थी, ट्रांसवर्स लाई थी, हाथ में कॉर्ड थी. तो एनीवे, हाँ जी.
So pregnancy delivery complex में, pregnancy delivery and postpartum complex में the most deadly combination or the most severe problems, the nightmare, the deadly nightmare for us is the bleeding that may be at the time of labor and delivery, that is the PPH, और infections, because जैसे अभी हमने बात की कि लीकिंग हो रही है, या वो घर में ही आसपास दाई किसी से बार बार चेकअप करा के ऐसे आते हैं, yeah, hygiene they don't maintain and they get infection. The postpartum sepsis may be there, or hypertension, as we have talked because of the dietary changes, because वो 9th month लगता ही वो घी 8th month से ही घी पिलाना शुरू कर देते हैं, दूध में घी, yeah, otherwise भी they change their dietary habits, and because of physiological changes also there is risk of increasing blood pressure. So for these are the three common causes which lead to pregnancy complications, means the near miss situation as well as the maternal mortality, and associated with it the delivery complications, means like if vaginal delivery there are many tears, traumatic PPH, atonic PPH, so all these conditions occur. So in labor room, what can we do about it? Means we have to train our staff for that. Dr. Manisha? So what are
Yes,
the
ma'am.
warnings we have
I'll
to
say
tell
that.
our staff? So what should be the frequent intervention or what should be the frequent detection model for us? अपने स्टाफ को, क्योंकि डॉक्टर तो पूरा टाइम नहीं रह सकते, तो we have to train our staff also. और what is your protocol to tell them कि इन सब चीजों के लिए कैसे ध्यान रखना है?
मैम ड्यूरिंग लेबर अगर पीपीएच हो रहा है तो मैम उसके बारे में बताना है. एक्सेसिव ब्लीडिंग इफ दे आर हैविंग, हेल्थ केयर प्रोवाइडर शुड बी well trained to handle a case of PPH, क्योंकि mostly the pregnancies and childbirths are not that complicated, but complication किसी भी आ सकती है. So judicious patient intake should be done. अगर लो रिसोर्स सेटिंग है तो किस तरह के पेशेंट आपने एडमिट कर रहे हैं, जिनमें ऑलरेडी हाई रिस्क पेशेंट है वो नहीं एडमिट करने हैं, और जो ड्यूरिंग लेबर ब्लीडिंग है उसके लिए एक्सेसिव ब्लीडिंग में मैम पीपीएच के लिए उसको रूल आउट करने आना चाहिए कि timely intervention, call for extra help, and uterine massage or uterotonic should be given. Or if there is some traumatic, then if she is able to handle, or she should call for some extra help for that. And postpartum period में अगर patient आ रहा है तो
the person should be
pardon ma'am?
able to the call you have called, the person you have called, they should be able to
expert handle
and we
it.
should have
Yes.
all the emergency drugs available, and if needed timely referral after stabilization.
Yeah, timely referral is the key to
even if at periphery some other medical specialist is attending the patient, so they should know the initial drugs which to stabilize for the stabilization of patient. So any views about it? Patient has eclampsia in periphery, so just for awareness of whether our medical specialist, the doctor, MBBS doctor is on duty and patient gets fits, convulsions, so what should he do at that stage before referring the patient?
Then he should first, if the Maxhelp is available, then they should give the Maxhelp dose. The loading dose of Maxhelp should be given. Then catheter should be put. Then FHS and this monitoring should be done कि baby live है या नहीं है, and with the loading dose of with IV loading dose, each patient can.
At periphery also, we should have the antihypertensives in their emergency
antihypertensive dose, yes.
And the periphery,
injection labetalol can be given.
Yes, so nowadays for bleeding, control of bleeding, we have medications. Just name a few medications which can be safely given at periphery for prevention of PPH as well as for management of PPH.
Ma'am, like oxytocin drip can be started. That is 10 units of Synto in 500 ml of normal saline. Or injection methargine should be given 0.2 ml IM, IV or IM. Then even misoprostol can be inserted rectally. Or if the prostaglandin is available, the injectable prostaglandin, prostodin injection can be given IM. And even the new drug, the carbitocin can be given. 100 mg of carbitocin IV should be given.
And while referring the patient, one doctor will accompany the patient.
Yeah, the health provider should accompany the patient during ambulance, and the uterine massage should be done. And even they can try for vaginal packing. कुछ available नहीं है तो condom on catheter, they should be trained about this, and they can put the pack in the vagina, and they can refer the patient with continuous monitoring.
Yes. So we have delivered a healthy baby, but how can we know the baby is healthy? So how can the baby warn us that मुझे बचा लो, मुझे संभाल लो? So what are the red flags in newborn's health, immediate delivery के बाद, what precautions we should take, and what are the warning symptoms? Dr. Shubhangi?
Ma'am, first we should see the color of the baby. If the color of the baby is pink, that's a vigorous baby. But agar baby thoda blue hai, then we have to see whether it is peripheral cyanosis or central cyanosis. Peripheral cyanosis is mostly because of hypothermia. तो अगर हम रेडियंट वार्मर के अंदर बच्चे को रखेंगे तो थोड़ा दैट विल इम्प्रूव विद टाइम एंड धीरे धीरे हमें लगेगा एक्सट्रीमिटीज पिंक होने लगी हैं. And if there is central cyanosis, then the neonatologist will definitely tell the baby to be shifted to the nursery, and relevant tests like echocardiography or other tests that will need to be done. Then if the baby is not crying properly, feeble cry, or baby is not responding to pain stimulus, so we see the Apgar score also at 1 minute and 5 minutes. If that is more than 7, then the baby is almost vigorous. Then we should rapidly dry the baby, and under the radiant warmer give vitamin K to the baby to prevent the hemorrhage. And after that, within 24 hours, if the baby is not feeding properly, if the baby is not able to pass stool or urine, and if the baby is developing icterus or jaundice very soon within 24 hours of the delivery, then also we need to see the well-being of the baby, and we should always call the neonatologist to our help to see, even if we know that what is the problem, we should definitely involve them.
Dr. Meenu ma'am, your views about it? Something like kangaroo care or anything, as if resources are not available with us. What can we do to keep the baby warm?
Yes, the baby can be put to the mother's breast with kangaroo care, like the mother will feel confident, she'll be distracted also while the doctor is stitching up the episiotomy, she'll be happy, the baby will also be put to breast and start a little bit of the sucking activity. It'll keep the baby warm, and that's one thing which we can do for the baby. And if everything is baby is pink and it's if they're having any problem, airway, some secretions, then we have to do the suction and all, of course. But if everything is good, then we can put the baby to mother's breast on the mother's body. That will give a good contact, warmth, and the mother will feel good, and the baby will, of course, feel good.
And another thing, every delivery should be preferably be attended by a pediatrician. If not possible, we must train our staff in neonatal resuscitation. So time to time, courses should be taken for the neonatal resuscitation.
I suppose now you all call for every delivery, no?
Yes. All times
for
not possible. Yes, our staff should be trained for that. So we have delivered, everything is fine. Now patient comes in postpartum phase, and baby is born. Everyone is happy that they have a new baby, new toy in their family, and they forget the mother. It happens very frequently. So how does it feel, Dr. Manisha? Do the mother feel they feel ignored? Baby is not given to them. All attendants are keeping baby with
very much stressed during this postpartum period because तो उसकी sleep cycle disturb हो जाती है, and she is already in pain of post cesarean है, episiotomy pain का है, so she is already in lot of restriction, family restrictions भी बहुत ज़्यादा होते हैं कि ये नहीं करना है, ये नहीं खाना है, so she feels very much depressed, and mentally she is not very good. So the families, relatives, and the partner should help her to cope up this postpartum depression. Postpartum phase is very important. The family support is very important during this phase. For her physical recovery, for mental and emotional health, it's very important.
What are the warning symptoms of postpartum depression commonly encountered?
Ma'am, mostly she will be not very happy about anything, and she will ignore the baby basically. She won't like the baby, or she will not feed the baby during this phase, and she will मतलब खुश नहीं रहती है, और दूसरा रिस्ट्रिक्शंस के कारण बहुत ज़्यादा परेशान सी रहती है कि बेसिकली स्लीप भी उसकी डिस्टर्ब होती है, फीडिंग की वजह से प्रॉब्लम आती है उसको, तो उसको लगता है कि मेरे ऊपर एक नई लाइबिलिटी आ गई है, एंड सिर्फ मेरी अकेले की रिस्पॉन्सिबिलिटी है, तो वो नहीं होना चाहिए फैमिली में.
because
Sometimes they have crying spells also, crying
yeah,
spells
crying
also.
spells,
They,
unable to sleep for many
Yeah,
nights. They
unable
are
to
unable
sleep.
to sleep, and that makes
Yes,
them disoriented. The patient
very
is
distant.
withdrawn. She doesn't want to feed her baby.
Feed our
So
baby, yes.
if these are the warning symptoms, if you find that she is saying that I am not feeling good and she is behaving like this, so what should the family do? कि ज्यादातर बोलते हैं ये तो सबके साथ होता है, इसमें कोई नई बात नहीं है, अभी नया नया बच्चा आया, you will get adjusted to it. But we have seen very abnormal events, means untoward events, and the sad outcome for this. So, madam, what is your opinion, ma'am, Meenu ma'am, about the postpartum phase and recovery?
see, the mother is the queen if the baby is the prince or the princess. So she should be treated like a queen. She should be given a lot of attention, tender, loving care. She has been through labor. She's brought a new life into the world. तो उसका मतलब care तो बहुत important है. She should be psychologically attended to, talked to, and in case 1% patient is on antidepressant earlier, they should continue taking. ये नहीं कि बच्चे को फीड करा रही है. जैसे मैंने एक इंस्टेंस बताया था कि मदर को शी वाज ऑन एंटी डिप्रेसेंट्स एंड द मोमेंट द बेबी वाज बोर्न दे सेड कि अभी बच्चे को फीड कराना है, डोंट टेक द मेडिसिंस, एंड शी गॉट वर्स एंड शी कमिटेड सुसाइड आफ्टरवर्ड्स. आई मीन इट वाज रियली सैड. इट वाज अ हेल्थी बेबी. So but she should continue with the medication which she was taking. She should be the priority, of course. The baby, सारा focus baby पे चला जाता है, तो she feels a little left alone. And anyway, she's tired, exhausted. She's to feed her baby. She's got sleepless nights. So she should be attended to with lot of tender, loving care and emotional care. Yes.
So, what are the warning sometimes? Means at times it is said that even if she says once that I want to commit suicide, don't take it lightly. It is for the everyone. If someone has suicidal thoughts, must consult mental health specialist, because that is a very severe red flag, because she may do anything anytime in such postpartum phase also. And if someone is going through low mood, so we should counsel them, take partner and family members into confidence, and just counsel them. This is a phase because of hormonal changes. So if mild symptoms are there, and as madam rightly said, that we should support them. Good nutrition. After delivery, usually they don't give water. पेट निकल आएगा, मोटे हो जाओगे. So you shouldn't take water. So they become dehydrated.
Dehydrated.
They don't take bath. They are not allowed to brush their teeth.
Brush their
That kind of
teeth.
things are there. Not allowed to eat anything. In some cultures, for 7 days they don't give them proper food.
Food.
After seventh day, we will start you chapati or the normal food, and during that time they get constipation, anal fissures. So many complications occur in postpartum phase. So postpartum counseling of the patient and her attendants is very important. And these are the red flags the family should never ignore. As madam has told, one patient committed suicide. Similar thing happened in one of my patient also. She lost her baby as well as she lost her life along with that. So never, family should never miss such warnings, and doctor should also be alert. So that is a very important cue. If she is very sad, she is not talking to anyone, she is withdrawn, not taking her baby, because she may harm her baby also. So mental health specialist involvement is very crucial. But if we tell them to go to mental health specialist, they just family says it is a stigma. वो
Stigma.
पागल नहीं हो गई है, हम उसको पागल का लेबल नहीं देना चाहते, इसलिए हम डॉक्टर पे नहीं जाना चाहते. So counseling is very important in that phase too. So that is the role of family and community. इंडियन कल्चर में, नॉर्थ इंडियन कल्चर में, वो जो सास होती है वो अपनी बेटी को बुला लेती है. जब उसकी भाभी की डिलीवरी होती है, द गर्ल कम्स टू हर पेरेंटल होम टू टेक केयर ऑफ हर sister in law. That is a very good culture that supports her mother in law as well as the patient also. So for family and community involvement is important. So we have taken care of our patient, and at some stage we find that we can't do, it's not good for us to conduct that delivery. Means we are in a situation to surrender. That is a white flag. So what kind of situations, Dr. Shubhangi, have you experienced in a situation of surrender, white flag?
Many times, ma'am, because we have a low, very small setup. So sometimes severe cases of preeclampsia or impending eclampsia, if we see, we need to refer them also. In case of extreme preterm conditions, we have to refer them to a senior neonatologist. And in case of sepsis, chorioamnitis, also the better newborn care is needed and better maternal care is needed. So severe vaginal bleed antepartum hemorrhage. It may be because of placenta previa or abruption. If it is heavy bleed, then the patient might land up into coagulation failure, which cannot be taken care of at our centers. So we need to refer that time also. And if the patient is having uncontrolled hypertension and along with it, the renal compromise is also there, or cardiac conditions are there, we need to refer the patient there also. If the patient is having severe thrombocytopenia these days, I don't know what is the reason, but we are getting cases of so many cases of severe thrombocytopenia. We may have to refer them. And obviously we always need the help of senior neonatologists, anesthesiologists and radiologists in our uh, during our practice. And also fetal medicine specialists in case we require amniocentesis, or there are congenital malformations, or in cases of Rh negative pregnancies or fetal anemia due to viral infections like parvovirus, we may have to advise the patient to go for intrauterine transfusion. Then we also have to refer the patient.
So it's not, we should not take it as our failure. If we
Mhm.
need to refer patient to
No, no,
a
no.
better facilities or better care, so we should take it as a surrender, and with mutual understanding, we should tell our patient that we are taking these consultations or we are referring to you another place for your betterment. Because at
Yes.
times we have seen, अगर हमने आगे भेजा तो उस डॉक्टर को नहीं आता, इसलिए वो हमें आगे भेज रहे हैं.
Mhm.
So we should know our
I
limitations.
always tell them, डॉक्टर हम भी वही हैं, हमारे पास भी वही डिग्री है, वहां पे भी वही है, पर वहां पे एक ही छत के अंदर बहुत कुछ है. सारे
बहुत सारा
डॉक्टर्स आपको ब्लड बैंक
डॉक्टर
फैसिलिटीज एवरीथिंग यू विल नीड गेट अंडर वन रूफ. एंड इन केस सम पेशेंट्स रिक्वायर इंस्टीट्यूशनल डिलीवरी, आई ऑलवेज टेल देम यहाँ पे एक गायनेकोलॉजिस्ट है, वहां पे 15 खड़े होंगे आपके लिए इफ यू नीड. Because in
Yes.
cases of cervical ectopic pregnancy or scar ectopic pregnancies, these cases are to be definitely handled in an institutional setup, not even higher center, institutional setup, which may be PGI Chandigarh nearing to us, or
So sometimes the pregnancy needs teamwork
yes.
from the patient, her attendants, her clinician, as well as she needs the larger team. At times she needs, because of her situation, she needs a bigger team. So the WHO has put up all these warning signs. The many authorities, ACOG, all has given these are the red flags. So why these are missed, and when we should seek help? At times we know that this is a warning sign, this ये patient हमें परेशान करेगा, even then we miss these things, और फिर बाद में होता है वो हमने इसको भेज दिया होता है या कुछ किया होता है. What could be the reasons on the part of patient, her attendants and her clinician? Dr. Manisha?
Sometimes the symptoms we consider it ki normally a pregnancy symptoms hai, so we miss the warning signs sometimes, and even the healthcare relatives also miss some warning signs or red flags के बारे में. If they are not well informed, then they can miss the, वो घर पे ही रखेंगे patient को. Then sometimes the inadequate prenatal checkups, if they are not regular in checkups, then we can miss some complications or red flags. Some problem, not the health provider is not very much trained, or is less trained, is not aware of, she is not having any information about the red flags, proper red flags, or the relatives are not very concerned about this. वो बोलते हैं कि नॉर्मल सिम्टम्स है, ये तो होता ही रहता है प्रेगनेंसी में, चक्कर आना, वॉमिटिंग, तो दे कंसिडर इट एज ए नॉर्मल, they are ignorant about their red flags.
So there are two terms. One is maternal mortality, that is the extreme, that is the loss. But short of that, there is severe acute maternal morbidity and maternal near miss cases. So in our practice, if we see, we may get at times such kind of situation. So that is also कि बाल बाल बच गए. We say कि बच्चा बच गया, mother बच गई. But we should avoid to reach to such a situation. For that is why the red flags are important, and we should be always vigilant about it. For each and every step, means every antenatal visit of a patient, we should be very careful while treating that. It's just routine heartbeat check किया और हमने उसकी growth देखी
हम
भेज
सिंपल
दिया.
भी, जैसे कभी पेशेंट आता है फॉर डिक्रीज फीटल मूवमेंट्स, तो हम उसको जैसे आईवी फ्लूइड देते हैं और मूवमेंट्स ठीक फील होने लगते हैं, देन वी सेंड द पेशेंट. और नेक्स्ट डे या थर्ड डे पेशेंट आता है कि मतलब फिर से
loss.
लॉस ऑफ फ्रीडम मूवमेंट से या आईयूडी हो जाता है, तो इन सच केसेस तो हेल्थ केयर शुड प्रोवाइडर और द डॉक्टर शुड बी वेरी मच अवेयर अबाउट दिस थिंग्स, अबाउट द कॉम्प्लिकेशन, एंड
Yes.
काउंसलिंग ऑफ द पेशेंट इज इम्पोर्टेंट.
Yes. So key message, ma'am. Now we are concluding the session. Dr. Minu, just one liner. What do you want to convey to our doctors as well as the community?
We should train our patients, explain to our patients what are the red flags, because sometimes they will not know anything. We give them sometimes in writing with the nutrition chart or something. In case of this, come to the doctor. In case of bleeding, case of leaking, decrease fetal movements. So writing them is okay, but explaining to them is also very, very important. And then they should come for a regular antenatal visit. Then only we can look after them. ना घर बैठ जाते हैं फिर महीने बाद आ रहे हैं जी अब मेरे को ये हो गया वो हो गया. So single messages: listen to your doctor, listen to the signs. This is for the patient, and for us we should explain verbally also, besides in writing, that these are the warning signs, these are the red flags. Please do come on time.
Written and verbal advice is the most
Both,
important.
both.
Their ear and their eyes and brain, all things should be in coordination for them and for us too, because we should also listen to their complaints so
We should
diligently.
also.
Yeah,
We
Dr.
should
Manisha.
listen to the patient. कभी कभी अकेले बुला लो तो ज्यादा अच्छे से बताती है पेशेंट अपनी बात, ऐसे मुझे लगता है. हमारे इन्फर्टिलिटी वाले तो आराम से हस्बैंड को भी भेज दो, मदर इन लॉ को भी भेज दो. लिसन टू हर, एनी लिटिल कंप्लेंट, लिसन टू हर.
तो मैम उस सबकी अलग कहानी होती है, मदर इन लॉ की अलग स्टोरी होती है, पेशेंट की अलग स्टोरी होती है, तो वी आर नॉट एबल टू जज कि किसको कब बिलीव
One
करना है,
more thing,
किसको नहीं.
ma'am,
वो
we
कहती
should
है वो
always tell that Chat GPT or Google are no
नो, हाँ, दे आर
like
नॉट
those
गुड
kind of doctors. So they should
इन्फॉर्मर्स.
not only see Chat GPT and Google and follow that advice. And even traditional practices also, like कुछ लोग कहते हैं 8वें महीने में चेकअप पे नहीं जाना है, ये
नहीं
नदी
मैम,
पार
नहीं
नहीं
हो सकती.
करनी है. So these traditional practices also मतलब they should not follow. और ये पंडित को पूछ के जो टाइम लेके करते हैं सारे, मतलब even one of my patients, she completed her 38 weeks on a particular date. I told them कि previous cesarean था कि आप elective CS कराइए. उन्होंने कहा नहीं, हमें पंडित ने बोला है, हमने मई में डिलीवरी करानी है. 6 दिन लेट आए मैम, the baby had meconium stained liquor, और उसके बाद वो बच्चा 6-7 दिन निकू में रहा. तो वी शुड डेफिनेटली टेल देम कि पंडित, ये जो फेथ है ये सब कुछ ठीक है, अगर कोई भी प्रॉब्लम है, थोड़ी भी प्रॉब्लम है, दे शुड डेफिनेटली विजिट देयर डॉक्टर. लेट द डॉक्टर डिसाइड कि what she thinks is right or wrong for the patient. If the doctor thinks that yes, we can wait until your pandit thinks the right date, then you can definitely wait. Otherwise, go by your doctor. No Chat GPT, no Google, no pandit.
And Dr. Manisha, your message to our society and our doctors.
So a healthy mother can give a healthy baby. So and in future she will have a healthy family, and that will lead to a healthy society. So the care of the mother is very important. Antenatal, postnatal, every time. So new concept of fourth trimester is also I have heard कि postpartum period में भी after 3 months of the delivery, that period is also very crucial. तो उसमें भी बहुत ज़्यादा care की ज़रूरत है mother को.
Pregnancy related complications may affect up to 1 year. So it is said that prior to these 2 years of her life, as we say that 1000 days in a child's life, which includes the conception phase onwards,
Conception period.
1000 days including the conception. And similarly for a woman's life, 3 months prior to conception, then 9 months of pregnancy, and then coming 3 months, as you have told, the fourth trimester. But the effect lasts up to 1 year. Means the 2 years are very important, which are affected by these hormonal changes as well as the physiological changes, giving birth to a child and bringing a new life into this world. So thank you, my esteemed panelists. It was a really
Thank you very much.
enjoyable. I think our
Thank you
audience
very
has also
much.
enjoyed it. Thank you.
Thank you.
Thank
Thank
you,
you,
thank
ma'am.
you, ma'am.
So should we close, Ada?
Yes, ma'am. Thank you, ma'am, for this wonderful panel discussion, ma'am. And on behalf of IGCP, ma'am, I sincerely thanks to all our speakers for sharing their expertise and all our participants for joining us, being an active part of this important conversation, ma'am. Let us continue to stay widely informed and committed to safer motherhood, ma'am. Thank you, everyone. Have a wonderful and peaceful evening ahead. Thank you.
Thank you.
Thank you.
Thank you.